So we want to make sure we have clear leaders. So that's what we expect from that team. And we talk about formal leader who's leading that critical event, but also like maybe your primary role where you come and you're like, I don't have a documenter, because maybe your doc is just, you know, focused on the airway or on the patient, so maybe they're not using their peripheries kind of skewed. So you want to say, okay, I need you to record. I need somebody to go get the crash card, something like that. So you have like a couple of leaders in the room. So that's really with leading teams. And leading teams, really, we would look for that person to huddle to. Like, so it's like, okay, what's going on? We've done this, we've done this, we've done that. What else, right? Because that kind of brings the hierarchy down and say, this is about the patient. Then it gives everybody a voice. Maybe all we needed to do was check the blood sugar, right? And it might come either from anybody in the room, so we have to give everybody a voice to speak up. So that's what we look for in a leading team as well. And then to debrief later as well. If you have any kind of events in your team, take that 5 minutes to debrief afterwards. We get all exhausted, and then we kind of go about our way, and we kind of leave feeling like there's something missing, right? It doesn't have to end like in an event where 911 is called. But even if it's just minor, it's like outside of what normally would have happened with the patient, they're like, hey team, let's quickly debrief to see what's going on with, what can we have done better? Is there a resource issue that we have? Do we have a gap that we didn't maybe recognize? So what can we do moving forward so this doesn't happen again? Or what do we need more training or something like that we want to identify, right? So the second one is situational awareness. You always want to make sure you're aware of your surroundings in a sense, like, if the vital signs are dropping, or if there's any changes, even if you don't recognize the rhythm at that moment, like there's a rhythm change, right? Because then everybody's aware of what's going on. The patient is not talking to me anymore, or something like that. You want to say it out loud so everybody's aware of what's going on in their environment, right? And then it kind of leads you to do certain things, right? Because if you say, I don't have a pulse, then it gets you like, oh, I'm going to go get the crash card, I'm going to call 911, I'm going to call for help. Like, it just kind of triggers different things to happen. So that's what we want to see, like, to speak up on that. Mutual support is something we do all the time. We just put a name to it now. It's like, I got your back, you got my back, right? If I'm doing CPR and I'm getting tired, what are you going to do for me? Relieve me, right? If he's trying to intubate, I'm on my tippy toe. It's like you need a stool, right? So it's just mutual support. You want a second line on this patient. You're coming in, you're looking at your situation, and you're going, this patient something's gonna happen. Maybe you need a second line, so that means like, okay, I got your back, you got mine. And we do that all the time, like first year of nursing, right? Because you're like, okay, you're overwhelmed with these patients, you have the heaviest load, you're like, oh my God, who got pissed off today? Right? And then you're like, hey, I see your meds like 30 minutes over. We do it all the time. It's just a name to it, and we should do it consistently. Even when somebody gets tired, when we give that feedback, I need you off of that chest, the chest compression. That is also a way of giving mutual support, is to give that feedback, right? The big one is communication, right? Because it is the third leading cause of sentinel events, so we just need to make sure we continue to communicate. And we've been tracking this since the 90s, and it's still maintaining the third, cause of sentinel events. So the main things, like for the core team, we look for closed loop communication. A lot of orders are given out and nothing is coming back in. This is just orders out there, right? Because that person giving out the orders is not getting any feedback. So close the loop, meaning the sender sending the information. I need you to go get the EKG. I'm gonna go get the EKG. You want the EKG? And then he shakes his head. And then you come back with the EKG's here. We need to call 911. What happens if you say that? Nothing might happen, or everybody's gonna go try to call 911. It's like, even if you forget, maybe I need you to call 911.
I'm calling 911.
Thank you. And then you come back and say,
I called 911.
I've called 911. 911's on the way. And so your documenter is like 911 called, 911 on the way. So that kind of gives that recorder as well of events that's happened, because that's your record keeping. And you want that as well written as possible and timely, right? Because like document like this is going to court kind of thing, right? Because then that's your documentation, and using that documentation as your way of communication as well, and then making sure you guys know where that document is, and using it as your legal documentation. So that's closing the loop. The other one is, now you have your core team, and now you want everybody else to come in and help you. So that's your contingency team, right? It might be your nurse, your CDU team, your anesthesia team could be the one that you called. So when they come in, or the rest of your staff that's going to come and help you, you want to give them a quick report on what's going on, right, and what you want them to do. And the way we do that is using SBAR, right? Co-critical communication. What's SBAR? Situation, background, assessment, and then your request or recommendation, right? So we put the R first because we think that if you say, I need you to intubate, then it's easier to go, this is situation, background, assessment, and then request. It sounds easy, but I want you guys to practice that today and then moving forward in your practice as well. And then saying, if you have something critical, you want to say, hey, I have an RS bar for you. And then so that triggers, if we all do it, it creates that culture of like, if I say RS bar, then it's a critical information. I need to stop what I'm doing and listen to you, right? Because if you say, hey doc, I have something to tell you, they're like, yeah, what do you need, right? But if you say, I have an RS bar and we have a mutual communication tool that says that means there's a critical patient, then it kind of just pauses everything, kind of focuses on this patient that we might be time-sensitive treatment needed. So you want to say, hey, I need you to come in. I need this patient to be intubated. He's here for this situation, and his background is this. My assessment is, it can even be a diagnosis. He's in respiratory failure, right? Because his status is dropping. And then I need you to intubate. What do you need, right? So you want to make sure you practice that today. So we're looking for that as you perform. All right. Any questions on the tools? Just practice your RS bar, closed loop communication, and then just speak up what you're thinking. Okay. For the mannequin, he's got a carotid pulse. If you haven't worked with this mannequin before, I encourage you to come and feel his pulse so you guys know where it is. I don't think it's femoral, so what today. Feel his carotid pulse. Yeah.
This one's not working.
So this is your monitor. Like your monitor would be like you're hooking him up to the monitor.
I think it's been sitting in the car.
You guys use Entitle, right?
The one that I have is, well, I had emailed you, the leg is missing, so every time. You know, it's in the bag, but it's, when I picked it up from the simulation center,
He's warming up.
it's disconnected, like, so every time I take it out, the leg rolls.
Yeah, this one might not be working. We had a problem.
And I felt it up there. I felt pain.
But then I say, I used it a lot, it's ready for different in-services,
so if you have to come up to the defibrillator, so this is your pad. He already has his pads on, so you can just say, I have the pads on and connected. But to defibrillate him, just go through the whole motion. There's no pretending here. The only thing we pretend to
get charged up and shock and clear and shock like you're in the real code.
Yeah,
yes,
exactly.
no pretending.
No
Only
pretending.
medication.
Yeah, and only medication. Don't open them and say just verbalize. Whatever you give is given. Just waste it. Okay.
Yeah.
Alright, I think that's the mannequin in, I'll verbalize some things for you. Otherwise, we just expect you to take care of the patient just like it's real. So this is your time to practice, to make mistakes, to ask questions after the simulation. Because once you're in there, we kind of stop answering questions unless it needs it. So this is a safe space for you guys to practice and play around and then ask questions.
Yeah, make mistake. You can't kill them.
There is no test. There is no test. This is all about practicing.
The pressure is so low.
I know, yeah, I'll fix that.
Puts the pressure up, then you're gonna feel it more. Yeah. We should, because the pressure's so low, so it matches the pressure.
Oh, the blood pressure is, oh wow. Did you kill him?
But no, I didn't read his
No, you're right. It's different. Yeah, this side is way more weak than this side. I don't know why. Does that make sense? I mean, it doesn't make sense based on the numbers. It should be.
Yeah, the pressure is low, that's probably why. It's coming up. Give us a second.
We were talking and then we went to sleep.
think this is not feel strong. As long as I feel something, then it doesn't matter.
Yeah.
Right? As long as we feel something.
Aren't you going to have IV fluid when that's all?
When we call for it.
There you go. You got it now.
No, this is we're starting off with the dad.
That's what they said.
Dad.
That's what
Yeah.
That's what
She said, where's that IV?
Yeah.
How she wants to have
How about now? Can you feel it now?
But I did feel it.
Okay.
feel
No, no. You guys said it was a little bit low.
No.
Yeah, the pressure.
Feel it.
Oh.
All right, I think you can go ahead with this
Okay.
scenario.
All right, so if everybody else except for the team that's gonna stay in here, wants to step out,
But you wouldn't be here, right?
which,
So this would be your case,
yes, so
Mr.
I'm
John
gonna
Doe.
read the scenario
Okay.
and then we'll start. Okay, so a 42-year-old male patient presented for a colonoscopy. He has a history of Crohn's disease, chronic pain, surgical history of appendectomy, allergies to NSAIDs, his pre-op vital signs, his BP is 123/67, heart rate is 75, stats are 99%, respiration rate 16. The colonoscopy has been completed and 2 polyp specimens were removed and sent to the lab. The patient has received a total of 6 milligrams of Versed and 200 mics of fentanyl. The surgeon has left the room. The patient seemed to be waking up, but immediately falls back to sleep. The conscious sedation nurse begins to hear an audible snoring noise.
Was that initial heart rate in sinus rhythm? We've been in sinus rhythm.
Yes.
Okay.
Sinus
That's
rhythm.
okay.
And the pulse ox right now?
Right there.
Everything.
Oh, okay,
yeah,
everything is
95%.
at 95%.
Am I on any
95%.
oxygen? I'm on 2 liters. What am I on for oxygen?
He's woke up, so you took you
woke
took him
up
off
and his-
oxygen.
You haven't taken them off and
yeah,
still in the room with
yeah.
me. I haven't.
So we're applying the oxygen again. Well, we're not removing it.
And now
It's
he's
still
snoring? Okay.
Yeah.
So then I would just do like a head tilt chin left, and I would say, excuse me, Mr. Bruce. Hey, how you doing? How you doing?
He still does not respond.
Okay. I would do it.
Yes.
Sternal rub. Mr. Bruce, Mr. Bruce, and then I'm doing this.
Every time you drop the chin, you hear a snoring noise.
Snoring, okay.
I'm calling the doctor back.
Okay, I would, yes, I would say, can you get the doctor in for me? Then I would switch over. I would, at this point, I would switch over.
Dr. Richards.
Dr. Richards is somewhere charting.
Okay.
Then I would say we need to get some backup. We need somebody
Yeah, the
other than
other
Dr. Richards. I will put in a nasal pharyngeal, I'll put in nasal trumpet in, and then I'm gonna start bagging the patient. What are my stats if I'm bagging the patient? No, I'm supposed to be doing it, right? You said that's how we're doing it? Yep. Alright, so this is up. Can you hand me this? Thank you. This is, we have a tight seal.
Okay.
After the nasal trumpet is in, but I need the nasal trumpet. Do we have one somewhere that's open?
The nasal trumpet.
Okay.
You have a nasal trumpet? That's what we were supposed to do.
What's my sack right now? But I'm bagging the patient
Your fat
with
is
people coming
95.
in.
Where's your
Nasal trumpet. What card, right? Oh.
And then I need more help.
Can I get the what card?
We need more help in, and we need another doctor in the interim until the co-team arrives.
Yeah. Oh, what can I do?
All right, I have a 42-year-old man that's supposed colonoscopy. I need an airway put in. Patient is not responding to the intervention. We don't actually do it. Yes.
Anesthesia.
Can we check for a pulse? Can we check for a pulse?
Oh, no, but
Karen is
Yeah, that's maybe, but are we in PEA? Like, is that here? I don't know.
Very
Yeah,
far.
I have a pulse.
May I have
Okay, stats are 95.
Can we put him on the back? What?
We have a pulse.
Stats in there, 93%.
Is that the back?
No pulse.
No pulse.
Start compressions and then build the compressions.
I need a medication.
He's
nurse.
got a
That's
pulse.
gonna be
He has a
helpful.
pulse right now.
He has a pulse.
There's a pulse.
You're gonna be the medication. Okay, you're recording. Okay, and then Karen, you're gonna be the run. Stats are 91%. Where is anesthesia or a doctor to come back and you have physician in the room?
Anesthesia starts?
Physician in the room. Yes, there we go.
Can I get an ask part of what's happening?
Yes, this is a 42-year-old male. He has a history. Status post colonoscopy. He had 2 polyps removed. Once the procedure was open, he started to desat. Stats are now 91%. I put in a nasopharyngeal airway, but it's not.
Excellent. Let's transition to an oral airway. I'll take a
Oral
70
airway.
oral airway.
Oral airway.
Oral airway.
It should be there.
All right.
You're gonna act like that.
RH 114, stats 90%. Blood pressure stable.
What else? No, they said
Excellent.
that we can do it.
Excellent. We'll insert an oral airway. Excellent. We'll pop that in. Oral airway is in. Stats still 90%, going up to 91%. All right.
On his tap at 115.
Excellent. Starting to desaturate a little bit. Can someone go ahead and take a listen for breath sounds bilaterally?
No breath sounds.
All right. So no breath
No breath
sounds.
sounds.
Stats still 90%. Let's convert and go ahead and intubate. Can I get a 7.5 endotracheal and a MAC 3 blade?
7 out. Can I have a stylet and a syringe?
88%.
Can I open it? So
Yep, go right ahead.
Okay. I need a stylet, ENDO, and a syringe.
Well, that's
A tape.
excited. That's not going to.
No, I have the stuff.
There we go. There's a blade. There we go. I'll
And I
take
need
the
the
lid.
blade on.
Excellent. 88%.
Yes, we can.
Open it.
Excellent.
Okay.
Yep.
That's all
Go
right.
ahead.
You want us to open? You can, oh.
Yep, go ahead. Go ahead and open. We're at 90%. Let's go ahead and secure his airway. Excellent. Suction set up.
Suction is set up.
Excellent. And let's take a look. I can visualize
the bed up?
a lot of.
Yes.
Let's bring the bed up a little bit. And I still can't visualize anything coming up. Let's convert back up. Can I get an LMA size 3.5? And it's getting a little bit more challenging to ventilate.
This is safe. Safe.
And we have moving air right now, so it's still at 88%.
I don't think. Do we open this?
Yep, go ahead, open the LMA. All right, don't move it. Superglottic going in. And pop that in, pick up the mask up. And can we ventilate? Let's
Sure.
see.
Just in the breath sound.
Yes, you can.
So we can ventilate with the LMA right now. We're at 89%, heart rate's 118, and we're stable. Can we call for the second anesthesiologist upstairs, please?
Let's see.
Excellent.
Pressure 79 over 29. We have fluid going out. Wide open.
Excellent. And it's getting a little more challenging to ventilate.
So you have to say muck or test.
Oh, no. Oh, okay.
All right, we've lost pressure. We're going to be clear. All right, stop. Let's go to chest compressions. CPR.
CPR. She needs a stool. Can we get a stool?
And can I have someone keep time for me?
Okay.
Let me know with 1 minute increments.
Okay. Timekeeping.
Let's give 1 milligram of epi, and let's give.
Epi. Middle flush.
And please let me know when the epi was given.
Low 37.
Was the epi given?
At the end. Yeah, at the
Excellent.
end.
At the end, keep time. And we'll stop and check the pulse at 2 minutes.
Okay. Let me know when you need to switch out. Okay? All right.
And at the same time, we have the chest compressions going, we have pads on. Excellent. We're at what time?
1 minute.
Excellent.
We just. I will not.
We can go up to 2 minutes. Excellent. 2 minutes stop, check pulse.
Check pulse.
Any pulse? No pulse.
No pulse. Back on
Shockable.
CPR.
Let's check our rhythm. Shockable rhythm. Hook up the pads. We're in B
We
good.
all on. Pads
All
on.
clear?
Yep. Pads are hooked up. We're all clear.
Charging.
All clear. Charge to 150. There we go.
Hit the orange button.
Ready? Are we clear?
All clear.
Yep.
All right.
You didn't
Mention
charge.
your CPR?
I did.
Yeah.
It did, it delivered. CPR. When was the last administration of drug?
Happy.
1 minute more.
Let's go ahead and give amiodarone.
Okay. Amiodarone.
300.
300. There's a flush. Amiodarone in.
I'm gonna run in.
Let me know at the,
Second.
Second dose.
Yeah. And then the next is 150.
all right, let me know at the 2-minute mark.
Okay.
Switch up.
One more minute.
It's getting easier to ventilate. Good.
1 more minute.
All right, switching off. 2 minutes.
Alright.
We'll fast forward to 2 minutes.
Yes.
Oh, excellent. Let's check a pulse.
Pulse.
Check a pulse.
Rhythm.
No pulse.
Don't worry, we can still shock. Let's go ahead and shock again.
Okay.
Oh, let's shock. Charge up. 200.
And then she is on.
Yeah. We're recharge.
Charging.
I'm clear, you're clear, all clear.
All right.
Okay. Let me know at the 2-minute mark.
Okay, 1 minute.
When was the last dose of medication?
The last dose was 1 minute ago. Empty snacks.
Yep, let's give another milligram of epi.
Okay, 2 minutes. Want to consider what else flush? Do we want to
Okay.
consider what's happening with the patient and we will address all
The
the
HSTs.
Yes, all right.
That's it.
Hypoxia is being treated right now. There's no tablets. And looks like we have a change of rhythm. That's 2 minutes. Let's stop and check pulse. Do we have a pulse?
We have a pulse,
Where rhythm is normal sinus.
normal sinus.
Okay, let's
Blood
perfect.
pressure's
We're
a
back.
little bit low. You want a fluid?
We'll give 500 cc fluid bolus and go from there. 911's on the way, so
Do
we'll
we
get the
want
patient
amiodarone
prepped.
drip?
Not yet.
Not
Hold
yet.
off on the amiodarone drip.
Okay.
Good call.
I know I
Get
will.
the patient prepped and stable for
911's here.
transport. Excellent.
Largo ENT.
Excellent. Oh,
Does somebody want to give me a report?
Oh, yes.
60. Oh, go ahead.
No, and
Oh, it's around. 6-year-old man, basically brought in for endoscopy, was given bedazzole and fentanyl. Loss of airway, difficult to intubate, went into a shockable rhythm, was given epi ×2 and amiodarone ×1. Now with a stable rhythm in the background, but with no definitive airway. So we'd like to have him here to receive the definitive
And
airway.
blood pressure is still 38 over 29. We got to
All right, I'll take it from here.
There we go.
Alright. Good job, guys. Very good.
Alright, if we can turn off that machine so we can hear each other. So we like to debrief, we talked about it earlier, right? Because we
Yeah.
usually have, our leader, you want to lead us to debrief for this round, if
Oh, perfect.
you
So,
don't mind? That's what we would like you to do in a real situation.
okay, that's correct. So, looking back at the scenario, what do you think the positive things that we all did as a team together?
I think the communication was stellar. At
Closed
some
loop.
point. I think we had closed loop. I think we addressed, we assigned roles, which was very important, so everyone's not running around doing the same thing.
I think one thing we could have done, like,
Positive. Positive.
Good things. Don't beat up yourself.
High quality CPR.
Yes.
quality
Yes. Excellent.
and always check your room prior to coming in. Make sure that everything is in place so you don't look. I did have to turn my head a couple of times before I grabbed the ammo bag. So it's like, oh yes. So and it was right behind me.
I like the responsiveness time.
I like the fact that you come in, like, you are running the code as a physician. I need, next, I'm gonna need an LMA. Next, I need an ET2.
Yes.
This is the size, so it was very directive,
Clear.
and very concise.
Very concise.
Very
Yeah.
concise.
Because, yeah.
What do you think, Lost?
Yeah, I was just gonna say that. Very clear instructions.
I think as a group, you guys are on point with everything. Like it was, I think the communication. You had asked me. There's great close loop communication with the drugs and also suggestions. We talked about with the bed being up, little things like that. I think there was that dichotomy and offering extra things that worked out really nicely. Like in a given scenario, I love that because it's things I forget. Like I was down here trying to intubate. You're like, can I bring the bed up? Awesome. Drugs, things like that. That works out really well in this type of situation. So fantastic. Things that we can improve upon.
No, before we go into that, I want to say kudos. Like when the patient was going downhill, you actually said, "I need a physician here. I need an anesthesiologist here." and that was clear. So the communication goes out for Dr. Alexander to come in. So make sure you say, I need someone here right now because the situation is going downhill. So and she did it like a couple times.
But my attempt was first because the gastroenterologist had walked away. And we don't always have anesthesiologists on board.
Right.
So my first reaction was, please get Dr. Richards back in here.
Right.
And then we can call, because
So you have
she is.
some
But
so
you
we have a
couldn't
physician in
because
here.
he was away, so that's why
Right.
the repeat
And
is nice.
it was a good first instinct to get him, but in the scenario, he isn't here for you to help.
That was a scenario. That was the challenge. Is like you didn't get Dr. Richards.
Right, Dr. Richards is gone.
Right,
She's like,
Richards is gone. So then what's next? So then you guys worked it out. Okay, I don't have another physician. You did the job and you did what you can do within your scope. And then you said, okay, then I need somebody higher now. And you didn't give up till actually he came.
I have a question though, because I don't go in the rooms. Can the techs actually
They can run.
do like
Call for
I don't
you.
know, call for it?
Of course.
Be your
Yes,
runner?
they can. As long as you delegate,
Okay.
they can.
That is a test.
Yeah.
Okay. Because earlier, I only asked it because earlier they said the circulator is the one who call.
Because what
Yeah,
happened
but
was just
that's
the two of us in
not
here.
a scope of practice for,
I know, I'm just saying,
for
like,
one person.
In the,
So you can call for help
Anybody.
as long as you take that responsibility and say, I'm calling for help. Jenny's calling for help, or whoever that person is, then that's clear for anybody in the room. Oh, Jenny's already, I'm just making up names, but she's out to call for help. So
Okay.
you don't really need to have a certain skill set to do that.
Yeah, I noticed a lot of great closed loop communications, and I think that's very key. Don't take it lightly. What you just did was so awesome to just say, okay, do you have suction? I have suction. Do you have, what meds did we give? We gave this and this and this. So all of that closed loop really kind of moves you forward, and all of that suggestion. There was a lot of call outs. We call those call outs, right? Do we have our H's and T's? Can we, because you had a pause, right? I know we sped up the 2 minutes, but that's a long time. Well, after you give your drug and you shock and you do that, it's a pause. So it's like, okay, let's do our H's and T's. So okay, we start with the hypoxia done, and then just keep going with the temp and we have breath sounds, those kind of things that you can do. You guys got the backboard?
Yep, ahead of time.
Ahead of time. Maybe a second line would have been helpful. Kind of thinking ahead. You might want to put a second line because his pressure was still dropping. That'll give you another access line if you're pushing drugs and fluids. So that's something I wrote down. And then the amiodarone. Did I hear dose? Did I miss the dose?
Yeah, no.
So we said
I
150. We said the one, somebody yelled out 300, but we did say that this is the first dose that we were gonna do. So we corrected it, but you're right.
300 first dose.
So that's the good part.
Okay.
300
is 150.
So what was it again? I'm sorry.
300.
We gave.
150.
I gave
I thought we
300
gave
because it's the first dose.
300.
The first dose is 300, isn't it?
Yes. Is that what I just
That's what
didn't hear
I said. I said 300. I said I'm on 300. I did say that. I did. Because I was the one pushing it.
Second dose.
You're right.
I'm saying those is 150.
Yeah, and then stay on the chest. I know the first one we kind of
Right.
stayed off.
Right.
Stay on the
Stay
chest until we're ready to deliver the energy. And deliver the energy quickly. Like if you notice, it is a VFib arrest. The new ACLS protocol says energy as soon as you can get it, because a lot of patients, go into VFib arrest. So as soon as you see the VFib, even before you push drugs, you can just deliver the shock. So you're doing compressions, and then once it's charged, you pause. It is still in VFib. Deliver the shock, and then go back on, and then do your 2 minutes.
Now, question. Patient's blood pressure was still like 70/39. 911 is here, and the patient is about to go. Do we do anything with the blood pressure? Because this is definitely not stable. do we do, I mean, the fluids is going wide open, but the pressure is still 75 over 38.
They did put up.
Yeah.
So,
But I think they
So
might
we
want
get
to get in this
anesthesia.
way. It's not a reason to keep them here if I'm wrong.
So what
Right.
I would say is that if we have transport here,
Yeah,
again, normally they'll come with drugs, they'll say,
Yeah.
they'll start running on dopamine drugs, some people get
Okay,
dopamine, they'll have to use dope up to the PIV and
okay.
get them stabilized and send them before he decompensates again.
Yes.
But I would delay, if he has a pressure with the post arrest, it's not too bad.
I mean,
Okay.
Yeah, it's like post arrest, you just wanna make
The goal is to get him to a higher
But again, you gotta try to pull them out as much as you can Ross.
It's Ross?
Yeah.
Okay.
And then, send him, because they have their own protocol they can follow, to
Okay.
get his pressures up if
Okay.
they can't.
Okay.
Because if you start a drip, then it gets an iffy situation where maybe you're gonna lose your anesthesiologist because then somebody has to go.
Okay.
Get that
Okay.
pressure started, so
All right.
kind of think about those things.
And I think they send like a different team when they're intubated.
The critical care team.
That
Like
will-
a different team,
Well,
EMS.
I mean, 911 is gonna have everything for advanced, for ACLS. They'll have all the capabilities. You're right though, sometimes transport, if we transport to a hospital,
Yep.
we have to specify that we need an ACLS crew, yes.
Yeah.
So for us, I think it did happen here, but a whole crew didn't go. I think just the pulmonologist went. Yeah, because he was the one who intubated. I think Dr. Schistler couldn't go because, he intubated. But I think it was Dr. Len that might have went, because Schistler had to get back for something. But yeah, it was just one person.
Most
who
of us
went.
to go.
Yeah, physician
Yeah,
has
they
to
did go,
go.
but the pulmonologist went that time.
Yeah.
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 They do.
That's why I see you like, are you sure you want to start a drip, because then you have to go with the.
Yeah.
Yes,
with the
if you start a
patients.
drip,
So
then
we
they
do a
would
lot of
they would
push
ask
on
you to
it,
go with
yeah.
them.
So just why don't we get these?
You Uber back.
They bring
Uber
you back
back.
sometimes.
Alright.
Is it
Otherwise,
because we're in an ambulatory care setting? Is that why? Yeah. Like
Well-
from the ER, like if a patient leaves from the ER, the anesthesiologist or the ER doctor never goes. Unless it's a patient who's like, who's a patient that's pregnant, who they have to transport really quick to get to a labor and delivery, then the doctor goes just in case they deliver in the
no,
rig.
it's the drip, the ACLS.
The ACLS drip.
911 will not take drips, is what.
Okay, but during the
They'll
day,
take
yeah,
the
the doctor
fluids
doesn't have to
running,
go.
but they don't have pumps to
Okay.
do your drips for you.
Alright.
So are you sending the
Okay,
pump with?
Right.
So it kind of
It
gets
gets
a little
sticky.
tricky. It
But
Yeah,
the
it gets
critical
sticky.
care team, if they send a critical
Interesting.
care
Yeah,
team, that's
that-
they
they
have their
come-
own
Yeah, critical
equipment
care
to do
team
all
is
of that.
different, yeah.
Oh, okay.
If you're, because the hospital's sending that critical care team or the ambulance,
Right.
but if it's just a 911 ACLS,
Oh, okay.
they will take the fluid with them, but they can't do drips.
Drips, okay. Any
And they don't have
pressures?
protocols for
Yeah,
those
they have
things.
their own medical director that they talk to, so they wouldn't, even they wouldn't take an order from the clinician
Question.
that goes on.
Question for you guys, because I'm not, in the ENDO setting, is you guys use the nasal airway, like you put in a nasal trumpet first, is that your practice before oral airway, or what's the preference here?
That's
we
what I
usually
would
do oral airway.
I would have, that's just what I decided. I don't know.
Okay.
I decided on that.
A lot of times in endo, because of the EGD, whatever they're having done, they may actually do this because they already have
Something in there. I just want to, I just want to understand.
Go with the bite block is to put the nasal airway in.
Nasal airway, okay. And is that stored somewhere in the room?
Yes.
Everybody knows where it is?
Yeah.
And
Okay.
then the procedure rooms, it's in that drawer, there's a kit in every bedside drawer with trumpets and oral airways.
Okay.
But in reality, my input,
I made them, that's why I made them.
the physician, they also need to be here, because for us to say, well, I'm putting him, don't do that, why are you putting a nasal airway? So I really do feel that, it would be good for everybody to be here, so that we're not intimidated by doing what we need to do for the patient's safety.
But I think if your physician is there and they see that their patient is doing bad and you say, hey doc, can we put a airway in or something, I don't think that you're gonna get too much pushback.
Yeah.
And if they've already left the room, if they're not available, you have to feel comfortable.
To do it, yes.
But you gotta make sure that patient is really in trouble.
But if I see some hesitation.
You got gagged.
So I see some hesitation. So if you have that communication challenge, that we call it.
And there is.
You can challenge. You respectfully you can challenge. Hey, I'm really concerned. You know that we call it cuss. I'm concerned. I'm uncomfortable. It's a safety issue. But if that's not working, and you challenge again, and it's not working, then you do have your chain of command that you can reach out to Debbie and hey, I'm really not feeling well, and I tried to communicate in a way, but it didn't go across. What can we do? That's why you have leadership here, right? And then the communication continues. But I don't want you to feel like you can't speak up, because that's not the culture we're trying to promote here. Really speak up. If you think it's a patient safety issue and you have that barrier, make sure you speak up in a very respectful way.
And I would just add, you all, that's why we have you do ACLS. See your patient crashing as what happened during the COVID. I don't think I waited for anybody to tell me to give an epi. I said, give an epi. If we went forward, the code was working. So that's what you're supposed to do. Afterwards, if you cannot say, the reason I gave epi was because I had no rhythm, you have to give like he said, cuss, yes, give a reason why, but by the time you're waiting for all this to happen, and you could have put that nasal trumpet in, your patient could be decompensated, right? Even more. So if you're waiting for the physician to feel comfortable to tell you to do something, but you, in your gut, know, hey, my patient's getting ready to go down. The sacks are dropping, I have to put something in, and I have to manually start bagging. Now, like she said, make sure that they aren't, because if they're awake enough, they're not going to let you put that nasal and they're not going to let you put it on. And guess what? That means you woke them up, and we're good. Let's go.
Anything else?
No, I think this was fun. This was a great group.
I have a question though. I see like dopamine drips here.
Oh, that's what it was. I had it written down. One thing that
I know, I'm for DM, so I have to know.
What doctor you gonna send, Terry? You got your doctor that's gonna go? They're gonna give you an eye. Terry's gonna get an eye.
So there's a big opportunity.
There is a big opportunity, and you guys did a great job with the code card and bringing the code card in right away. But you wanted to also get the difficult airway card, and I'm recommending that anytime you have a code that you bring both of them, because if you're gonna need to intubate and anesthesia's coming.
I know, you got everything you needed, because they
know how to, they really know how to get stuff out of here.
Everything you needed is in.
I was like, what? Yeah, I was like, yeah, I got everything.
You have an airway set in there, but you never asked for
And
a
the
live.
lights
You
were-
didn't
I didn't need it.
You had already gotten the patient, so it was like, okay,
Right.
we didn't really need it, but
Okay,
somebody
so both
still should
come.
grab it.
Right. Because if
Yeah, if you have a difficult airway, make sure you bring the difficult airway card, because it's set up in a way that's geared to anesthesia. So
This part up there.
I know the gyroscope stays in this one.
No, and then
The gyroscope will always,
the
that
gyroscope is right behind our.
Hopefully we will have it moved soon, but.
Alright.
Yeah.
well,
So you only have one, there's only one gyroscope.
Oh, no, I got it.
That's
We only have
right.
one.
There's only one down here.
Down
It
here.
stays in this room,
It
let's say.
stays in
down
this
here.
one always.
Because we only
In
have
this room.
one room.
But what if you have a
So you grab it from here?
No, that's a very good question, because when pain
So
is
if you have
here
a
and there's
case,
a
you're gonna
patient
come
here,
into.
there is a challenge, there's a C-arm over here, so it is hard for you to get that out
So
there.
why don't we keep,
So maybe we should
One
put it
lines
in
in one
or
room.
just keep it in a central location, so that's what happens, like
Yes.
Holy
I
Cross
don't
and
think you
stuff.
are.
We have,
Where the lights go.
It's right here.
It's always.
So what I'm
I
saying.
know, but I thought they moved it out.
No.
It's
Oh,
behind.
okay. Is that the gyroscope?
Yeah, right there. It's right here.
Right behind you. There's no way you're gonna get
You
it.
can't put that back there. No, that's a mess.
Yeah.
Yeah.
Because even if run in during a case and get that out.
Yeah.
Again, this is just my 2 cents in the subject
No, you're
matter.
right.
No,
Everywhere
That
I've
needs to
always
get out
worked is
from
that
there.
we've always
It used to
kept.
be out here. in
Yeah,
the
it's in a
little
centralized
somewhere.
location,
But
so
I don't
anyone
know
can
what
get to
happened,
it.
why we started leaving it. I guess because nobody thinks about B and C needed it.
We just think
But
that.
they don't need it for every
Or if you have a
case.
code out there and
Or
someone
in
needs
the,
it,
yes, or in the.
they might not know it's
Yeah,
here.
she made a good point, because pain uses this room.
Yeah, so this is, you see, this is why we do senior living. That's gonna be, if you've been asked to bring that, and there's a case running here, you would never get that on time.
No.
That's actually
this is-
perfect.
Yeah, this is already.
That's perfect, that's,
Like, a lot of anesthesiologists come down and it's right there and they'll be like, where's the glasses? And they'll be looking for a while.
But it's
Like,
hard.
that's why I said,
No,
like,
but you're not looking, I'm telling you, it happens though. So many times I have an anesthesiologist, they'll come and they'll ask for it. And we'll point. Even Dr. Bell came in here and another anesthesiologist asked.
But it was
She's
out?
like, it's right here. No, it's sitting right there.
She gets it over.
Yeah,
She's used to
it's
Right.
blocked.
She's used to
There.
it.
Plus there's wire running,
Yeah,
all
it's
the
true. It's
nitrogen
very
and
painful.
everything, so.
And if pain is in here, you're not getting that.
Right, you're right.
You got a patient slam here and a C-arm over there.
Oh, really?
can't. Yeah, they set up the room completely different. So I agree. That's a good
Yeah,
question.
so we'll have to
Just
look
let
at
it
that,
move.
moving on to a
So
different
what
area.
should probably happen then from now on the days that pain is here,
Move it out.
to leave or
Let's just
whoever-
But it should probably be,
It should probably be moved.
I highly recommend to be on a centralized
Yeah.
location.
Yeah.
Blood test, they need to do
Okay,
that.
let me think about where,
Yes.
because that's the problem. We don't want it to be somewhere that everybody just runs by it.
because if you have a case in here, you're not gonna be able to
Right.
get to it.
No,
even-
we won't be
even
able to.
Is it possible it can fit between the airway part and the MH part? That way
It
it's next
used
to
to
the
sit
airway
right here
part?
outside this room, so I'm not sure why.
They end up there.
They should
Because they put a stretcher.
Right next to the airway part.
She's
right?
afraid.
It should be. Figure it out.
Because
Because this is very important for you.
Well, maybe
So you have to bring it out from there and bring it into the room during that case.
During those cases,
And then
if
put
we
it back
had
out
those
there.
cases Monday and Wednesday.
Yeah.
Yeah, we don't want those advanced cases with
Yes.
and bronchoscopy without the.
You have the
Without the
other
bronchoscope
part
is
in.
not-
don't wanna do
I
it.
would if I was.
You have the,
Because you need it.
But then they can bring it in the room.
I know, I know.
It's a standardized process, so just everybody knows, like, are we moving them out during pain, are we
Somebody
moving
may
them
ask,
during those
but
times?
because generally,
And just having that one location, that everybody knows where it is.
So if they really needed a second one, if they're utilizing this one and they can always call for one upstairs at the ASC.
So just kind of think about it as a team,
Or, you know,
you might just have to trial it out to see, depending on how much is
You
long.
can make it maybe a part of the text come and set up in the morning, so maybe we can make it a part of their setup. No, because then on the days when pain is here, where is it? That's the question. You're right, it doesn't. even-
Can it be where the
I don't wanna say it
yes?
that way.
That should have cluttered right there. I don't know.
Yeah.
It could
I
be.
think it just.
Yeah, you guys just have to figure it out.
Yeah, so this is something that you have to figure out. Really, it's a problem, obviously, but you have to figure out where it should be. And you know, you have how many procedure rooms? You have 3. So you have 3 procedure rooms and then a kind of a patio area there, right? So try to figure out, hey, where should we put this? This is an equipment that we may need.
Right out here,
Yep.
in the hallway by this room where it used to be. I'm not sure why it's in the back of the corner.
Yep.
But right here, because then everybody can get to it easily. That's where it used to be when I first came down here. I'm not sure how it migrated back there, but I think it was anesthesia.
When they use it,
I think anesthesia and the techs like to make sure they check it and they have everything together when they come to
Yeah.
check.
Because one time it was an issue where the adapter, we couldn't find a
Correct,
cord.
things were missing, so they wanted to try to keep everything together, but we can move it out of the room physically and put it here like it used to be.
Yeah, and sometimes, you know, if you're not oriented to that equipment, some people think, oh, it's blocking my hallway, so let me just put it on the side. They don't know exactly how critical that equipment is. So make sure you kind of, oh, this is a critical emergency
No,
equipment. You
that's
can't
what they
just
do in
move
the
it.
hospitals. They
Yeah,
put
they do.
and it's sort of weird, but they put blue tape around that. Like the Holy Cross cords, like in the cord, there's like 5 of the glide scopes with blue tape around that.
Yeah.
It's sort of weird, but you're like, no one touches it. It's like,
It's
scary.
individual.
Yeah.
So that everyone knows that it goes to the doctor.
Yeah.
Yeah, so
Because
after
that's what
after
blue
this
tape
COVID crisis, you know, everybody makes money.
I know.
So they came up with, you know, a tape called high visibility tape that you put it around, and I mean you can get that tape around to make sure that that's
The same
area.
thing with like the
And-
ultrasound, everything
Yeah.
has a, because you don't want to put a square on it, but you put like a little blue thing
Yep.
around it.
And people would know, oh,
Goes back
that's
inside the
a
square.
an area, emergency
Alright.
area.
Ding, 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 it's 12 o'clock. I don't want anybody to say I held you here longer than what I said.